So good afternoon, everybody. My name is Noa Dagan. I'm a physician by training. My focus is on public health, but I'm also a PhD student in the computer science division in Ben-Gurion University, focused on practical implementations of machine learning in medical databases. And I'm also the chief data officer of the Clalit Research Institute. I think both the Clalit Research Institute and myself share an interest, which is practical implementations of machine learning solutions in healthcare. And this is what I'll be trying to talk about today through several examples. So for those of you who are not familiar with the Israeli medical system, Clalit is the largest HMO in Israel, as was said earlier today. We have pretty unique data in terms of the broadness of the data. We have over 4.5 million members. We have both the data from the community setting and the hospital settings. And we are also the payer and the provider, so we have both the claims data and the clinical data. And all of this data is also available for a very long period of time because the Clalit was digitalized over 20 years ago, and the attrition rate in all of the HMOs in Israel is very low, so usually when we have data about someone, we have it for a very long period of time. The Clalit Research Institute is a group of very talented people, very multidisciplinary group of clinicians, data experts, statisticians, machine learning experts, and epidemiologists that have received the mandate to take this data and to turn it into something that you can actually do something about. And I think that is maybe what makes us rather unique. We are taking this obligation pretty seriously, and that's why we try to make use of every type of data that we have, starting from structured data, through imaging data, and textual data. I will try to give brief examples of each and every one of these today. So in terms of structured data, I think that the big challenge that we had a few years ago when we first created our first prediction models is maybe a bit different today, because we have prediction models that are based on structured data that are out there and being used for more than, I think, 7 or 8 years now. And currently we're not in the phase of developing them, but in the phase of testing how well they did and how they actually changed medical outcomes for individuals. For readmissions, for example, we've been able to show that the rate of readmissions for people at high risk was decreased by 12%, which is amazing. For preventive nephrology and flu vaccinations that are all sorted by the risk by prediction models, we are currently in the phase of evaluating what good we did out there after the models have been active for several years. And I think that if I'm talking about structured data and prediction models, the main challenges that we face today in this field are a bit different than cleaning the data and creating the model and training the model and proving that the model is accurate. One of the biggest challenges that we currently have is to try and make this model transparent, because we understand that in order to put them to practice, physicians have to understand why we say a certain patient has a high risk for a specific disease. This could be done by using white box models instead of black box models, like more simplistic decision trees or regressions in which you can see each and every one of the coefficients and understand why a specific patient has received a high risk. But also we are exploring more sophisticated ways like the SHAP models of machine learning in order to understand how we can tell the story to the physician when he's receiving a specific risk, how he can believe us that the risk is accurate and is, to a way, equivalent to something he would understand as a physician based on what he learned when he was in med school. The second thing that we are currently trying to focus on is to do prediction models based on structured data very quickly, because we have the capacity to do it. So we're trying to make the phase of the training more fluent and more thematic as we can. And we also try to make the implementation of these models in the field much, much quicker and much more agile. So if we create a model, our expectation is that within a few weeks, that model will be able to be in the server of physicians in the field. And that was not the case a few years ago when we basically had to take each and every model almost manually to give Excel sheets with the results to the physicians. So we're trying to change all of that, and that is a big challenge, but that's a challenge that we're trying to take on today. And lastly, we are very interested now in the consequences of what we do. So if a few years ago our focus was how do we create prediction models from all the data, there's a lot of data, it's very dirty, and we need to clean it, and we need to create the prediction models, and how do we do it, and how we take on the new technology. We've passed that point now, and now we're trying to understand what it is that we do and how we affect ethics in medicine today. Because if we create a list of patients at high risk for a specific disease, and we tell the physicians, look at this list, treat the ones who are on top of the list because they're of the highest risk first, that basically means that someone else at the bottom of the list will not get the same care he used to a few months or years ago. But it gets even more than that. You have to ask yourself the question, who is in the top of the list? Who should be put there? The one with the absolute highest risk, the one with the absolute highest percentile compared to his age and gender? Or maybe the one that you can actually do something about, because the specific risk factor that has brought him to the top of, or her to the top of the list is something that is changeable or easier to change. And we're also doing it not only in the phase of the implementation of the models, we're also concerned with the ethics of the modeling process itself. So we're trying to take algorithms, advanced algorithms, with partners from the academia in order to understand how accurate these models and whether or not when we train a model, it is fair to each of the patients in the cohort. What does it mean to be fair to the patients? It means that if you have a group of patients that are underrepresented in that cohort, for example, a specific ethnicity or a specific age group, you want to make sure that the model will not take the easier way and be accurate to most of the people, but will forget in some sense that small group of a minority. So we're trying to create algorithms to run after we train the prediction models and fix the calibration of the models. Why calibration? Because we and the literature believe that calibration to some extent is the most important thing in terms of accuracy, because this is basically how you make decisions. So you want to be calibrated, meaning you want the risk to be accurate. If you tell someone that he has a 10% risk for a stroke in 10 years, you want that the risk will be correct and not just sorted correctly. Sorry, not just discriminatory. So basically what we do here is take all of the different minority groups in the prediction models, and we make sure that the calibration plots, which you can see here in the slide, or the computer is a bit slow, are as possibly on the diagonal, because the observed risk and the predicted risk are the same. If you take all of the different minority groups with all the different combinations of variables, you get to 500 or 600 groups. If you take the age group and the ethnicity and the socioeconomic status and the sex, etc., and you multiply all the different categories, you get to a very large number of specific groups you want to be calibrated for. And we've been able to show that we can take calibration measures that are not so good for those minority groups and fix them. Here in this slide, you can see the different groups on the x-axis. You can see the calibration measure, which is called calibration in the large, in orange, before we fixed the calibration of the models and made it fair. And you can see what happens to this calibration after we conduct a new algorithm for fairness and make sure that the model is calibrated not only to the largest group, which is on the left, but for the smallest groups on the right. So this is basically where we are with structured data, and as I said, we are beyond the phase of just creating prediction models. We are in the phase of making the best prediction models, the quickest prediction models, to put them to use very quickly and to do it in an ethical and transparent way. In terms of imaging, so computerized vision is something that is very advanced today. From the different fields of machine learning and deep learning, this is probably one of the fields that is of the most promise. And here we work with a company called Zebra, which you will hear, I believe, next from, on a project that is meant to predict osteoporotic fractures. And again, we are very focused on practicality. And this slide tells you why we chose this disease. We chose this disease because it's preventable. We can actually do something about it. We chose this disease because it is of very high burden. Okay, it has very high incidence, as you'll see next. Almost 10% in 5 years. If you take major osteoporotic fractures, which is a group of different fractures, it has very high morbidity and mortality. People who suffer hip fractures usually end up either capacitated in some way, or they die in a rate of about 30% in the year following the fracture. This is very, very, very high risk of death. And this disease costs a lot of money. Also, this disease has the advantage that guidelines already recognize the importance of prediction models. So if we will create a prediction model, it will be very practical for the physicians to actually use it, but the existing models, which are based on clinical information, are very underutilized because it takes a lot of time. You need to be aware of the risk, you need to feel the model, and basically you need to understand that this is something you need to think about when a patient comes into your office with a completely different complaint. So in this project, what we do is basically take CT exams that were performed for any reason, given to Zebra Medical Vision, which creates for us 3 markers of bone health. And what we then do is cross all of this information with a lot of other clinical variables to predict an outcome of hip fractures. We do it with every chest or abdomen CT. Now you need to understand that for people at the age of about 50 years, this is very, very common. So we have CTs for about half of this population, somewhere in the system. And these CTs can be performed for any reason, with or without contrast, so it's very non-limiting. What Zebra does is create 3 different markers of bone health, the first being compression fracture. We talked about transparency. This is transparency because theoretically Zebra could take those CTs and create a prediction for osteoporotic fractures as a black box, and we would not know why a certain patient is of high risk or not. But no, what we do here is something that is very transparent. We say this patient has a high risk because we found that it has compression fracture in his vertebra. The second marker that they give us is a DEXA emulator. DEXA is the bone density exam that you do in order to identify the risk of osteoporotic fractures. But here someone did a CT for a completely different reason, and we tried to take advantage of that CT and create the same proxy of a DEXA exam. And last, they give us the medullary density of the vertebra because this will be the part that will break. This is the part of the bone that is the weakest part, and that is the part that will break. So we believe that that part should have predictive value in order to predict fractures. What are we competing with? We are competing with FRAX. FRAX is our benchmark here. FRAX is the prediction model that uses clinical data in order to predict fractures. And this data basically means about 16 to 17 clinical inputs. It takes a lot of time to collect these inputs. What FRAX does is predict 2 different outcomes, the hip fracture and the major osteoporotic fracture, which is a combination of 4 different fractures, as you can see here. And what we did is to try and test whether the markers from the CT that are basically computed completely automatically, and you don't need the awareness of the physician or the time of the physician in order to create them, could compete to some extent with the prediction ability of FRAX. So here we took almost 50,000 individuals, aged 50 to 90 year olds. And we took only patients that had CT in the system prior to 2012, so we will have enough follow-up time to see what happens in their future, whether or not they actually sustain a fracture. And for each of these patients, we created 3 different predictions, one based on the FRAX, another based on the CT, meaning those 3 markers that I've told you about, plus age and sex, which is data that could be found in the metadata of CT. So theoretically, this prediction could be calculated completely automatically within the CT machine. So when the CT report comes out, a patient could have the risk for osteoporotic fracture in that report. And the third is a combination of the FRAX and CT that takes the inputs both from the FRAX and from the CT predictor and creates one final prediction. And then we compared the risk, again, the computer is a bit slow, but we compared the risk to what actually happened to these patients down the line, whether or not they sustained a fracture. As you can see here, the results are pretty amazing. We found, and we were very surprised to find that the CT predictor is actually better than the FRAX predictor for every single measurement that we've tested. That means that you could take those CTs completely automatically, calculate the risk fracture, and it will be better than the gold standard that is currently integrated into guidelines today. This is a ROC curve of the different models, and you can see that what I've showed you just now, which is basically for specific cutoffs, is true all over the curve. All over the curve, the red line, which is the FRAX, is lower than the different lines of the FRAX and the CT and the FRAX-CT combination. And the FRAX-CT combination is even better than the CT alone. So if you have both sources of data, you could potentially create the best prediction model. In terms of calibration, again, the calibration curve, you see that the FRAX is much, much less calibrated than the CT and the FRAX-CT models. And this is to be expected, because usually when products are taken off, prediction models are taken from a different population and transferred to a new population, they are less calibrated. But that could be fixed. What could not be fixed is all the measurements that I've showed you in the previous slides. All of the discriminatory measures that basically sort the patients based on the risk will not change a bit if I will recalibrate the FRAX to the Israeli population, and we have. So this study basically shows us that we can transform the care of osteoporotic fractures. We can prevent these fractures because currently these patients are underdiagnosed and not treated because physicians are not aware of the risk. They do not think to calculate the FRAX, even though it's out there online and theoretically they could. And if we can find and pick up these patients that are of high risk, we can treat them and we can save them and give them many, many more years of healthy life. The last project I want to talk to you briefly about is a project that deals with text. The motivation here is clear because I think it was said earlier this morning, most of the EMR, most of the health record is basically unstructured. 70% of the information in the clinical record is textual. And these records are growing massively because unlike in the past when we had one file with the previous admissions of the patient, now we have everything from the time point the fund was actually digitalized. So we have 20 years of admissions and 20 years of summaries, and no one can go through this amount of information. So in this project, what we try to do is to see if we can take clinical texts and identify ICD-9 codes from these texts completely automatically based on NLP, natural language processing models. And again, the motivation here is that someone was hospitalized 15 years ago, and the diagnosis was only written in textual format and was not documented as a structured field. The physician will be aware of it, and all of the different models that we do that are based on structured data will be aware of it. This is done in collaboration with the University of Columbia, with one of the greatest experts of NLP in the world. And again, this project is focused on practicality and transparency because we're not using specific NLP models. We are using only NLP models that highlight the text for us and give us attention, that's what it's called, so we can understand why they've decided to tell us that they think the patient has a specific diagnosis. So for this patient, for example, we can see a summary, and we can see that specific codes, specific ICD-9 codes were tagged for this specific summary, but a code that states that the patient has a chronic ischemic heart disease was not tagged. But you can see that the text, those of you, probably most of you can read Hebrew, you can see that the text clearly states that, and that the algorithm marked that text to tell us why it thinks that we forgot something. This example is even more, I think conveys the message even better, because this young female was admitted to the hospital because of an ectopic pregnancy, and a pregnancy outside of the uterus. And she underwent a surgery. And the summary states that. And it states that she was admitted for ectopic pregnancy. It also stated, structured data also states that she has asthma in the background. But it failed to state is that the physicians during the surgery found endometriosis in her stomach, or what they suspected to be endometriosis in the stomach. Why is it so important? Because endometriosis is a disease with very high morbidity that usually takes about 10 years of gap between the first symptom and the diagnosis. So this patient was already in the surgery. Someone already looked inside her stomach. Someone saw the marks of endometriosis within her stomach wall, but forgot to tag it as a structured data. And that means that basically it will probably get lost. Okay, this computer is... Okay, so basically what I try to tell you about it in a very short time, is that we try to do all of the things that we can based on the data that we have, and it's different sources of data. And we're also working with types of data like signal data that I've not mentioned here today. But we're doing it in a very practical, focused manner, because everything that we do has to be transformed into something that will change patients' lives. And in order to do that, we believe it has to be very transparent, because otherwise physicians will not use the tools that we create, and the patient lives will not be changed. That's it. Thank you.